So my name is Rebecca Brown. I'm Vice Chancellor, Chief of Staff to Chancellor Martin, and Secretary to the Board of Trustees. And joining us for this session are two of our top medical experts, Dr. Steve Lawrence, Assistant Dean for Curriculum and Clinical Sciences in the Office of Medical Student Education, and Associate Professor of Medicine in the Division of Infectious Disease at the School of Medicine. And Dr. Cherie LeBlanc, Executive Director of the Habif Health and Wellness Center on the Danforth campus and Assistant Professor in the Department of Medicine. Both have been key advisors in the university's planning for the fall semester, and I know everyone will join me in expressing our gratitude for all that they've done for us and to continue with what we do in our community. A quick housekeeping note, we will be taking questions from attendees live here, so feel free to put those in the Q&A box. And we'll try to get to as many of those as possible. We also have a number of questions that were submitted ahead of time, and those are continue to come in, and we'll work through those as well. We actually got a lot of questions, so we're going to try to get to as many as possible, but there is a time limit of 30 minutes, and we'll revisit that time limit when we get a little bit closer. We'd like to begin by asking the Drs. Lawrence and LeBlanc to start by giving us a brief update on the status of COVID-19 in the St. Louis region and filling us in on the latest preparations here on campus. Dr. Lawrence, what can you tell us about what's happening in St. Louis?
Yeah, the St. Louis region is still experiencing moderate levels of community transmission of COVID-19. We had a peak in April. It went down to a relatively low to moderate level in May and June. And then for the last 2 months now, we've seen elevated levels, but the epidemic looks different now than it did in April. We saw a lot of hospitalizations. Our hospital was nearly full. The ICU is nearly full. But now the hospitals are doing okay, and the cases are driven mostly by the, say, 15 to 30-year-old age group. And it really coincided with the summer coming and students really starting to get together with friends more and not pay attention so much to the social distancing, masking recommendations.
Thanks, Dr. Lawrence. Dr. LeBlanc, I know we've been very busy preparing for the start of the fall semester. Can you tell us what's happening at the Wellness Center?
Sure. You're right, Rebecca. There's been lots happening, and we are actually we've developed a whole new wing in the health center so that we can see patients that might have COVID-like symptoms in one area and keep people coming in with other symptoms that are not related separately. So that there's been some construction going on. We've been increasing our staff. We are setting up almost a public health department within Habif so that we'll be able to quickly identify our students who need to be isolated and quarantined, be able to trace their contacts and really monitor and follow them while they are in isolation and quarantine. So lots of work on the Habif's part, but we're excited to see things progressing as they are.
Thanks to both of you for those updates. We've got quite a few questions submitted ahead of time, so I'm going to go ahead and start with those. The first one is, given the experience of other schools, why are you not testing the entire community upon arrival in St. Louis? All students, off-campus juniors and seniors included, have access to in-person classes, dining halls, and other campus services. Also, why are you not conducting surveillance testing?
That is one that I will talk about. And if I could share my screen. Okay, so what I'd like to talk about is this has become the most asked question as we have been reopening. I am going to kind of blast through a few things and just with the realization that we don't want to spend the entire time on this very, very important issue. And it's certainly an opportunity to revisit this in future settings. And first off, I want to acknowledge that this is very stressful time for all of us to try to figure out how we're going to navigate this new world and, a new life on campus. And that, quite honestly, nobody knows the right answer. This is a 100-year pandemic that nobody has experience with. We don't know, and nobody knows, and they're fooling you if they say that they do, that there is a single right answer to approach this. And so what I wanted to do is talk about the decision-making process, what we are planning to do, and why. And to do that, I want to start off with just emphasizing a few really important basic fundamentals about COVID-19 that maybe everybody knows, but just to make sure we're all on the same page, is that the majority of the spread of disease from person to person is by direct contact. And that's usually with people who spend more than 15 minutes within 6 feet of another person. And that we know that many cases, on average, about a third of people with COVID-19 do not have any symptoms. And so we know that, we recognize that. That's a challenge that comes into the testing. However, we also know that those who do have symptoms are more likely to be contagious and more likely to spread it to a larger number of individuals. And that the other very, very important thing that we want to put this into the context of everything else is that layered prevention measures, all the mitigation strategies, when you put them on top of each other, they work. And that includes universal masking, physical distancing, limiting the number of people who get together, making sure people with symptoms aren't coming on to events around other people, and then rational cleaning and hand hygiene. When you put all these together, we know that they absolutely work at preventing transmission in a lot of settings, workplace settings, and school settings. So our testing principles and strategy are important to think through. Our goal is, with the testing, is to be able to minimize transmission and prevent large outbreaks. The principles behind this are that we want to, as much as possible, be evidence-based. When there are data that tell us that this is the right thing to do, we want to identify it and use it. We also want to be conscious of the limited resources for testing that are in our region, and we want to use those wisely and equitably. And the other thing to keep in mind is that not all tests are created equal. You know, I think we hear a lot about tests. It's like, well, I'm just going to go out and do this testing. It's really not quite that simple. And there are many different commercially available tests that are certainly available, but not necessarily adequate for some of the purposes that we're looking at. And then another important feature, there's new data emerging continuously, and we have to stay on that, and we are. And that there is, the testing is just one of several tools to mitigate the spread. We put testing into the context of those other mitigation efforts. So our strategy has been to ensure that we have the adequate diagnostic testing capability, to make sure that we identify cases on entry into those who are coming into communal living, and then we identify options for more widespread testing if needed. And our activities have been around those three major areas. So our testing plan as of today, and you notice I put this as of today because, as we've talked about, these are continuously evolving as far as what we know and what we need to do. But first off, the diagnostic testing, the most critical component, that is when somebody we suspect has infection, that we have the ability to identify it. And we have built an infrastructure on the Danforth campus that didn't exist as of even 3 weeks ago. It will be ready to roll by early next week to be able to then send anybody from the Danforth campus who needs diagnostic testing to have the gold standard PCR testing done with results back usually within 24 hours. It may be up to 36 in some instances, and it would be done on campus. Then the next thing that we have also are planning to do and will do is entry testing. So this is doing testing of every student who is coming into residential life, housing. And this is a population that historically would have a higher risk of transmission in any sort of communal settings. And that we do actually, as of even today, the CDC just published today an experience with camps in Maine that did show that an entry testing kind of strategy does provide some benefit. So there's some emerging evidence that there may be some benefit to this approach. And so what happens is that on campus, before people check in, and you'll hear more details about this, but then we would collect the specimens. It's a saliva test, and we'd have results back within 24 hours. And depending on the when they check in during the day, they may have the results back the same day. And then finally, the other thing that we will be doing is supporting outbreak investigations in conjunction with our health department. And when we do see that there are cases emerging or clusters emerging, that we can deploy testing in a targeted way to be able to do targeted investigations to see if there is a particular, say, event or location that there's ongoing transmission that we need to get ahead of. But the big question, and the one that we get a lot of comments and questions about, and it's really been quite remarkable, the number of comments and questions, is that is about routine surveillance testing. This is where we're testing a whole bunch of people who don't have symptoms to try to find who has infection and who doesn't. And in general, there is a lack of data at the moment for using testing for this purpose. We just don't know. All the experts in the world, nobody knows if that strategy is actually something that is effective or not. There's certainly a lot of reasons to believe why it might be, but we just don't have data. There are a lot of opinions on it, but while there aren't data, there are models that have been published, and some models have gotten a lot of attention, including a paper in JAMA from Yale and Harvard that showed if you do lots and lots of testing, like every 2 days, you can prevent large outbreaks from occurring, and at the cost of generating a lot of false positives. And then one of the things with all models, though, is that they are dependent on the inputs that you assume to make those models. And in that case, they actually assumed that there was really minimal impact of any sort of mitigation strategies, that all of the masking and distancing basically wasn't being used or not working. And there was an editorial that came along with that mentioned some of these. But then also to remember, there have been other models that have been published that actually don't show that there's any benefit. And so you can modify what you put in the inputs in those models to affect that. So let's think through the considerations of it that we've thought through. This is our decision-making process. The advantages of surveillance testing are that we would detect some, but not all, asymptomatic cases. But we also have to recognize the limitations that would come along with it. First off, it's only detecting a person's status at one moment in time. We know that because of the test sensitivities, there will be false negatives, and that can promote people to have a confidence that they individually do not have infection when indeed they might. And if there is a sort of widespread sense of like, I'm getting tested and my test is negative, I'm good until I'm tested again, there is a real concern for that undermining our mitigation efforts that we know work of masking and distancing, that there may be a relaxation of that. And because of that, we do have significant concerns. There might be harm to an approach like this. We want people to assume that everybody could have COVID at any time for all of the mitigation strategies to work, that we want people to assume that, I may be infected, so I have to undertake these strategies. And then finally, there could be false positives. Even with a test that is 99.9% specific, doing testing on a few thousand people multiple times a week could end up with over 100 people who are put into isolation for a false positive test when they actually don't have infection. And so we don't think that, at the moment with the data, we are concerned that there may be limited benefit for an individual. And then it's not clear overall that there would be a net benefit. We have noticed that there are features of college clusters that have been in the media and what have been reported, the experiences of other campuses, is that they tend to be associated with large parties off campus, and that they're usually associated with a super spreader event. In other words, one person, two people who then happen to be in contact with a lot of other people, and it's a bit of a bad luck situation, because we know there will be some parties going on, in every campus that's open, but some have had the bad luck of the super spreader event. And with communities and parties that are happening off campus, with mixing with other community members who aren't undergoing routine testing anyway, we just don't have a strong sense that that a mass testing surveillance approach is likely to prevent the scenario that these large clusters. And so that's the rationale behind it, the thinking behind it. But I also want to say, I don't know that that's not going to change. So many things with COVID change. We are constantly reevaluating the data, and as new things emerge, we make changes to our approaches on a regular basis. And I have learned with my years of experience of humility that, for me to, and for us as a group, our infectious disease division, in addition to myself, are the former past presidents of the Infectious Diseases Society of America and the Society for Healthcare Epidemiology of America. Both of those are part of our group that we have come to this conclusion that we are, at the moment, feel this is the right way to go, but things can always change.
Great. Thanks, Dr. Lawrence. Dr. LeBlanc, I think this probably is a great question for you. And this is sort of a combination of some questions that are coming into the Q&A and that were submitted in advance. And so I'll kind of consolidate them here. How important or helpful is a metal nose piece in a mask? Also, there's been mixed guidance lately about the types of face masks that are most effective. Is it okay to wear a bandana or a neck gaiter, or does it have to be an actual face mask? Does it matter what kind?
Thanks, Rebecca. You're right. These are great questions. And the key to our masks being as protective as we want them to be is really all about the fit. We want it to be a snug fit over your nose and under your chin, because we're trying to create that area to be completely protected. So the metal piece does help somewhat make that more snug, but not every mask has one, and not every mask needs one. There are so many masks that are out there. It's a matter of trying to find one that fits snugly but comfortably. Most of them are made of a cotton material, but what's important is that there are some layers in the mask, and that it fits very, very snugly. And so you probably already know what I'm going to say about a bandana or a neck gaiter, because they're not snug, right? So we really find that we're concerned that that's not going to give us the level of protection that we want. The other masks that we're very concerned about are the ones that have a valve on them, and you probably see them all over Amazon and all kinds of places. But the whole key of that valve is it's letting your air out, which is that's not what we want, right? So we find the mask with a valve is not something that we would think is an appropriate mask for our campus, and not a bandana and not a gaiter, because again, it's that snug fit that's going to give us the best protection.
Great. Thanks, Dr. LeBlanc. One more follow-up on that question, and that is, and I'm going to, again, just kind of freehand this question here. If I'm sitting in class with classmates who do not have tight-fitting masks, should this be worrisome to me? Is there anything that WashU is doing to prevent aerosol transmission? Should I be worried that the CDC has been drastically under-emphasizing the danger of aerosols?
Yeah, that again is a good question. I'm gonna pivot to Dr. Lawrence, because I do believe that he has a little bit more expertise about aerosolization, and I think that again goes to the question about the loose fitting mask. And so I'll bring that to you, Dr. Lawrence.
Sure. And so, that's the second biggest controversial question that we get these days, and the most frequently asked. So there is emerging evidence that, we know that the vast majority of transmission is by close contact with each other. And that we also know that you can find virus in the air that stays in the air for some longer periods of time in certain circumstances. However, we also know that the strategies that have been used to prevent transmission, masking all the time, staying 6 feet apart, avoiding people come together, all of those things work incredibly well. There's a tremendous amount of evidence that is developing that shows, how effective those are. However, that is regardless of whether in some rare instances, there is a little more aerosol transmission. What we approach this is that it might happen on rare occasions. It happens more often in the hospital with critically ill patients. Out in the community, probably really rare events, and that all of these measures that we use are effective regardless of whether or not there is some airborne transmission or not. But in general, as far as mask fitting, you want to make sure it's, does fit snugly. And we are in this together, and we are all going to have to help remind each other, say, hey, that mask is that's kind of loose there. And there's probably better ways to say that, but that we all want to help each other out to adopt the best practices.
Thanks, Dr. Lawrence. Here's one off of the Q&A. If WashU shuts down and goes online, like in March, will students living off campus still have isolation and quarantine facilities available to them? Students on campus will be sent home, but my daughter is living in a private apartment, not residential housing, and she will continue living in St. Louis. Will Habit Healthcare be available as well?
The short answer of that is yes. We are here, and we are here to take care of any students who not only live in the residence halls, but also off campus. I would imagine, I don't know that I've had that exact question about if we left, if most students left the residence hall, would we still be running isolation and quarantine? I can't imagine that we would not, because that is a key part of our strategy, and we would continue to do that. Even if your student decided to stay in her own apartment because that was where she was most comfortable, Habif would still be reaching out to her every single day by Zoom and monitoring her closely to watch her as she goes through COVID, or he. I don't know why I just assumed it was a she, but maybe you said that, Rebecca.
I said daughter. Okay. Here's a collection of flu vaccine questions that I'll consolidate. When should students get the flu shot? Is it a good idea to get it before returning to school if it's available? Will flu shots be available on campus?
I can answer that one as well. If the flu shot is available where you are right now, go ahead and get it. We are wanting every student on campus, and actually every faculty, staff, and student on campus, to be immunized against the flu. And so if it's available, go ahead and get it before you come. Bring in some documentation that you have had it. And yes, it will be available on the campus. We were hoping it might be available at the time of move-in, but I think for our supplies, it's going to be a little later than that. So we will be having flu clinics across the campus in multiple areas as soon as we were up and running with the vaccine.
Thanks, Dr. LeBlanc. Dr. Lawrence, this one is probably for you. We cover our nose and mouth with masks, but Dr. Lawrence has indicated that eyes are a third pathway. Are the eyes susceptible to airborne droplets, or is it the inadvertent touching of the eye area that creates the problem, or both? Do regular eyeglasses provide a meaningful protection for airborne droplets? If one does wear glasses, is there a cleaning protocol for them?
Yes. So in the hospital, we do recognize that, so taking care of COVID patients, for example, in that setting, that we do know that transmission of COVID can occur through the eyes. It's not as likely as through the nose and the mouth, but because of that, when we're taking in that high risk situation, we all do wear eye protection. And that consists of things that's a little more protective than just eyeglasses, because there's quite a bit of space, between there, but something that has more of a seal. That the two things we use are either face shields, that go like this and it stops all the droplets from coming in, or goggles. Now, whether or not there's a need for it in community settings, there has been really no concern or evidence that we've seen spread of COVID in a community setting that's not high risk through the eyes. And that would be further diminished when we use universal masking, so that the person who's infected, if they're wearing a mask, and by the way, that's the most important part about universal masking, is that the person who's infected is wearing the mask, because that actually is even more important than a person who's uninfected being exposed, is wearing the mask. But in that setting, we haven't seen outbreaks associated with transmission through the eyes. So we don't, at the moment, the evidence that's all available doesn't suggest that we need to recommend it for routine use. However, in certain circumstances where there may be a lot of close proximity work that's necessary for certain, types of instruction or laboratory courses, or in individuals who are very high risk, that can be a consideration, but it's not necessary for widespread use.
Great, thanks. This is an antibody question. Will students be tested for antibodies? Will students that have tested positive and finished quarantine or have antibodies be given more freedom?
No and no. But the testing for antibodies, unfortunately, doesn't tell us as much yet, because of the antibody testing. There's false positives, false negatives, and they're not that accurate yet. The other major important thing is that we don't know yet. Hopefully we will in another 6 months, but we just don't know yet how much immunity prior infection gives us. And so we also don't know if the presence of an antibody test, if it's positive, we think probably some immunity that would be protective, but just don't have the data yet to know that, to be able to relax restrictions on those who are known to be positive. And so those are things that, again, we hope to know more in the next 6 to 12 months, but there's just not enough evidence yet to be able to feel confident that a person who is antibody positive or previously known to be infected would be protected enough to be able to sort of be free of these restrictions.
Great. This question was submitted in advance. We understand that people can exhibit a variety of symptoms for COVID. Is an elevated temperature the universal symptom? Is it a privacy no-no if we take the temperature of our students with non-touch thermometers? What is the temp threshold above which we should worry?
I can take that, and Dr. Lawrence can join in if there's more to add. I would say that fever is a very common symptom of people who become sick with COVID, and so it's not universal. Though I don't believe every single person at some point has a fever with COVID-19. Though Dr. Lawrence may be able to say that more. So the other question was, is it a no-no to do a thermal scan of your student? I think each department is going to figure out their policies and what they're doing. There certainly are many places that are doing temperature scanning. We're doing it on the medical campus. For anyone coming into the hospital or any of the medical buildings. But I think what I would do is bring that question up through your department and deans and be sure that it's been vetted, that that's the policy that you all want to do.
Should students on campus be concerned about false negative tests hours after they have contracted the virus on a plane or bus taken to get to campus?
Yeah, and I think I might have typed a response to that if it didn't go through. But the thing with, yes, it's a possibility, although there is actually, if you take some certain precautions with travel, and these have been listed out certainly in a letter that was sent out by our Vice Chancellor, Rob Wild, and then Kawana Leggett with Residential Life. They have listed out a series of recommendations for safe travel. And if those are followed, the risk of infection during travel is actually extremely low. And so while testing at entry does not in any way preclude the possibility that somebody could be in the incubation period and then could develop infection later, the likelihood of developing infection from travel itself when undertaking these precautions is really quite low.
Great. We're getting close to time, but I'm going to take another couple of questions here. I don't really see people wearing masks in St. Louis when they're taking a walk or a jog, but I do see people trying to stay 6 feet away. How much of a concern is this if people are outside, staying 6 feet away, or not masking?
If you are not spending a significant period of time with that person, so if someone is out jogging and they just jog by you, that's not a risk. When we think about what is a risk of exposure, it has to do with the time and the distance. So again, 6 feet apart outside is a much more safe area. Outside is always a more safe area. But no, people out jogging or walking, everyone is giving each other distance, which is great. And I think that a very quick encounter is not going to give you something to be concerned about.
Is it safe to hug people you live with when they're in a high-risk category and you are sometimes out in public, like at the grocery store?
Everything is relative these days, but yes. And the main thing is really just identifying if you yourself are concerned about transmitting to a family member, you'll want to, the things that you should be concerned about is if you show any symptoms, that would be an indicator, and symptoms of COVID-19, that would be something that you should be very cautious about. Make sure that gets evaluated before any close contact with anybody. And the other thing is, have you had high risk activities? So going to a grocery store in and of itself especially if everybody's masked, especially if you are masked and you're using hand hygiene after you come out of the store, the risk of transmission in a grocery store is actually really, really low. One thing that I think I'd really love to emphasize is that the risk of transmission is much, much higher. The most risky thing that people can do is just to be around other people unmasked. So having a few friends over for dinner, having a few friends over to hang out with for a while in one room unmasked, that is what leads to transmission. It's not going to the grocery store. It's not even riding on an airplane. It's hanging out with people, even if you know and trust them, your best friends, your family members. We have to operate under the assumption that everybody could have COVID. I could have it, you yourself could have it. And if we all operate under that assumption that it's possible, that we're always masking, always keeping our distance, we can stop, really prevent all transmission. The transmission events occur when people get together unmasked. That's where all of the transmission occurs.
Thanks, Dr. Lawrence. Okay, we're just about at time, a couple minutes over actually, so we're going to go ahead and wrap things up. Thanks again, Dr. Lawrence and Dr. LeBlanc, for taking time to answer questions today. And thanks to everybody on the line who has joined us. We're hoping to do this again soon, potentially weekly, so watch the Danforth Campus Digest for information about that. It will also be on our WashU Together website, which is covid19.worcester.edu. And that's where we'll post the next link to the next town hall. We're going to hang on to the questions that weren't able to answer today and push them forward to the next meeting and the next event. And we'll also make sure that we implement them and incorporate them into our FAQ page on our website. Good evening, everyone, and stay healthy and safe. Good night.